Everyone, this is Charles Clinton, and I am currently a PGY2 in Savannah, Georgia. And I am doing this video because this is my second rodeo at residency. So I basically completed residency in Costa Rica about 5 years, and now I'm doing residency again here in the United States. So by this time, I believe that I have something to bring to the table, which is basically guide you, maybe as a third year, second year, third year resident who is starting to teach other learners how to do medical procedures or how to basically learn anything. I think this is a good video for you. I'll just focus mainly on two procedures we oftentimes do as internal medicine residents, but you might also be doing this as surgical residents or as emergency medicine residents, anesthesia. So most of you will probably be able to relate to this. So we have the central venous access, and we also have the arterial line placement. So let's talk about that a little bit. So it's now your turn to teach, and it is their turn to do and learn. So let's go on to this next slide right here. I'll try to talk about the 80-20 rule, which I see that might be something you know about, might be something you've heard in the past. To be honest, I do not recall who passed on this idea to me, but I think it's probably commonplace for most of us, but we don't usually apply it. So what it means is that for any good procedure to happen, or for any procedure to happen effectively, and hopefully on the first try, you'll have to do 80% of the time, should be preparation, and 20% of the time should be actually just doing the procedure. What oftentimes happens in hospitals is that we invert this, and we just go immediately to the action. We just try to go immediately to do the puncture the vein or get into the artery, and then we start thinking when things go bad. By this 80-20 rule, I would like you to try to change this and invert this as it should be. 80% of the time should be getting ready, and then when you have everything well planned, when you have everything prepared, when you have plan A in mind, plan B if A doesn't work, and even a plan C, that is when you are really prepared for the procedure. And guess what? At the end, you will be able to do most of your procedures on the first try, as opposed to having those procedures that you start quick and you're like, I'm going to do this in 15 minutes, and suddenly it is an hour and a half and you haven't done it, and then you have to call your attendant, and it becomes a 2 hours to 2.5 hour procedure, and you end up exhausted, pissed off, and a whole lot of work has already built up. So that's what I mean by 80-20 rule, and I can't stress this enough. I'm an advocate to do all these preparedness little tasks that I see that oftentimes now that I'm teaching my interns here in the US and also in Costa Rica, they would sometimes look at me as if, but why are you're preparing too much for this? It's like, I'm ready to go, let's just go. And sometimes I'm like, wait a second, okay, we have everything prepared. Have you already scanned the neck before deciding which is the vein you want to cannulate? And oftentimes the answer is like, no, we're gonna do it on this side, because the patient is like half contracted maybe to this side, and they're just like, we're just gonna do it on this side. So my next question is like, have you scanned the neck veins? Is there maybe a tortuosity? Is there a pseudoaneurysm? Is there a blood clot? Are there other things that might make you change your decision? Because what if you already prepare and you get all the sterile dressing prepared for this specific section, you have your gloves and everything is ready, and now you're seeing with the ultrasound and you see that there's a huge pseudoaneurysm. Then you're like, oh man, I should have seen this before. So now let's throw all this away and let's get another kit and let's sterilize maybe the inguinal area if you cannot do it on this side. So you get the point. So yeah, sometimes going the extra mile will take a little longer, but in the long run, it's a very good investment. And as I am telling you, and I have seen in the past, those procedures that you try to get in and get out quick end up becoming the longest procedures. So I will tell you a little story of when I had to do one of my first central lines. I was in Costa Rica. I was a first year resident, and over there they just tell you, you just have to place a central line on this patient. So I went, and this patient was like a 90-year-old female, and she was all like contractured, and she was completely bedbound, sarcopenic, and contractured. So it was very difficult to try to place something. It was mainly just the right jugular area. So in Costa Rica, the medical culture is a little different than here. In Costa Rica, it's more like, go do it and figure it out and tell me when it's done. Here in the States, we have more liability issues and other things that, yes, of course, it makes sense. And here, you won't go and just do a procedure on the first occasion. You'll have to see through several procedures, which, yeah, makes sense. But my point is, I had no idea how to do a central line, and I just had to go do it. And it was either just accepting to go do it and actually try to do it and hopefully perform it well, versus saying, I have no idea what I'm going to do. Because if you said that over there, you lost the opportunity, and someone else is just going to go ahead and do the procedure because they don't have time and they do not want to explain you the procedure or how to do it. So basically, when I was asked that night, there's this central line, are you going to do it? I was like, yeah, I'm ready. So basically, I had to go, I had to read, I had to go see, okay, where am I going into and what am I going to do? So I tried my best, and I tried doing this central line. I wasn't able to perform it. So then I called the upper level. The upper level came, and they didn't prepare at all. They just went directly to try to puncture, and they thought that it was the intern that didn't know what they were doing, and I'm just going to go in there, puncture, and that's it. They did the same thing. They weren't able to, and hematoma started like to form. And then after they tried several times, their ego didn't let them say like, okay, I've already tried three times. I'm going to let the attendant try, or I'm going to revisit my plan. They called the attendant. The attendant came, and guess what? Once again, the attendant now thought that the intern and resident had no idea what they were doing. So instead of planning and looking at the ultrasound and all that, they just went directly to try to stick the patient again, get the vein, and it didn't work out. So this was a pretty sad story because in the end, this patient got about 9 different maybe puncture sites in different parts of the body to get the central venous axis. And there was no planning, there was no framework, and in the end, maybe the central line could have even been avoided. So no one even revisited the question as to, do we really need this? Do we really need to keep generating this painful procedure? So that's one story, just so you guys understand the importance of the 80-20 rule. If you're a student, you'll see this happen over and over again. I know it's a very difficult spot to talk up to your resident or talk up to the attendant and tell them, hey, can we just try to plan this out? What are we going to do? Have we already seen the vein? Do we have the white thick tape just to maintain the patient in that position? Because if they move, it might be a problem. So I know it's tough. It requires a lot of assertive communication and very tactful communication. But if you're hearing this today, I recommend you to practice being assertive, to read the book Radically Candid, and that will help you actually probably be able to communicate these things. If you are the one doing the procedure or you're the one guiding the procedure, I would recommend you to go back to the 80-20 rule I just mentioned, because this is universes apart. It's extremely different what will happen on each. Nowadays, I do practice the 80-20 rule. After a couple, most people learn by their own mistakes. So after just going through the status quo, which is just, oh, I have to do a procedure, I'll just go try directly to go into the vein. Then you start encountering complications. You eventually might puncture an artery. You eventually might generate a pneumothorax. The patient, you thought that they didn't need any local anesthetic because they weren't moving, and suddenly you're going into the vein and the vein looks incredibly nice and great. But once you puncture, the patient just starts moving and screaming, and you're like, oh, I just waked up this patient, and I could have just used the anesthesia, local anesthetic, but I assumed the patient wasn't going to move, so you didn't invest that 80% of the time in preparedness. So in this image you're seeing right here, you're seeing that the vein, yeah, of course, the artery at the level of the neck, the carotid artery is more medial, and the internal jugular is just lateral, but it's always a risk. So they're right beside each other. You have to be able to position them to try to not put one on top of the other, which if you do hyperflexion, hyperrotation, you'll put the vein just on top of the artery. So if you puncture a little more, you're going to go into the artery, and that's a problem. So that's why you have to think what you're doing, and everybody's anatomy will be different in the end. So what you want to do is you want to use ultrasound nowadays. You don't want to go blind. What do I mean by going blind? Blind is what I learned, the way I learned to do central axis. Actually, I learned to do it here, right here in the subclavian vein, because everyone would do it over there. This is the year 2016, 2017, and just through palpation and without any ultrasound. Nowadays, you have ultrasound probably in most parts where you're practicing. So in Costa Rica, there is an ultrasound. When I was finishing residency, there was an ultrasound. Yeah, you had to walk like two blocks to get the ultrasound and bring it to where you were going to perform the procedure and then take it back, and you needed the key, so you needed to speak to the attendant. That's what I mean by preparedness. If you have the time, that's the 80%. Bring that ultrasound, look at the veins, and try to understand the anatomy instead of just assuming, instead of just imagining. In some countries of the world, in some places, you will not have the ultrasound. You will have no idea. So in those cases, yeah, well, do your best. And if you need to mark it with a pen, or there are some anatomical landmarks, you'll have to become a pro on understanding the anatomical landmarks. So where the sternocleidomastoid muscle has a division between its two heads, that's where you will go in. You will try to go in a little bit higher, because if you go a little bit lower, you might go into the lung, and you do not want to do that. So of course, sometimes the Trendelenburg is good because the vein gets more engorged, but it makes the lungs come more apical. So you have to take all these things into account. And as a learner, you have to ask all the questions you need, and you do not know how to do this procedure on the first time, so don't expect to be asked all the details of the procedure. If you're trying to do one of these procedures and your upper level is asking you to give them all the detailed procedures of step by step, probably the person who is guiding you isn't the best person to do it, because they do not remember when they themselves passed through that process. So the only way is to basically they taking you by the hand and tell you, this is the next step, now I want you to do this, and you have to be very calm, and you have to give the learner the sense of peace. And basically that's the way where your learner and yourself will be able to get out of this procedure unharmed, meaning that you'll be able to get it on the first try, maybe second try, no major complications. So invest that 80% of the time. And I've seen this once again over and over when I was here in the States. No one knew my past experiences in Costa Rica, and I could say it, but no one could actually see my experience. So I had to go through the whole process again, and I had to be supervised. And I was like, this supervision doesn't make much sense, because I know what I'm doing, and these people are supervising me, but they don't even have the gloves on, and they're not actually helping me. They're just standing there, and they're just waiting for me to fail. And when I fail, they're going to try to take over the procedure. And that's what I do not like, and I hope that doesn't happen to you, and that you do not do that to your future learners. So what I want you to do is I want you to very well prepare, and once you prepare, generate this calm, soothing environment for your learner and for yourself, and then just go for the procedure, and there it will be. So I'm not talking about emergent procedure. So if you have to do a central venous access and the patient is in a code-like situation, most of you shouldn't even try to attempt a central venous access, because it'll take you an eternity. It won't go well. And you know that in that case, you have to do an intraosseous access. There's the bone, you get the kit. There should be someone with a kit in your hospital, in most of the hospitals, and you should do the intraosseous access, and then you can place the central line if the patient survives and is stabilized. So that's the other point. Be honest with yourself. If it usually takes you 30 minutes, 40 minutes to put in a central line, and in normal conditions with a patient who is stable and who is following commands, and now you're in an emergent situation, and the attendant asks you, we have to place the central line stat. Can you do that? And you're like, yeah. And the attendant tells you, you have to put it in 15 minutes. And your answer is, yeah, for sure. No, you have to be honest with yourself. If it takes you 30 to 40 minutes to place these things in patients that are completely stable, there's no stress and all that, and now you're stressed out, how are you going to do it in 15 minutes? You're just going to generate a complication. Then the patient maybe isn't going to be coding, and while the patient is coding, you're not even able to suture these things, or you might go into the artery instead of the vein. So be honest, and sometimes it's better to even say, well, let's do an intraosseous, because I don't think I will be able to do this in 30 minutes. Or I can try, but understand that this and that. And it doesn't mean you're chickening out. It just means that you're being honest. Don't let ego get into the way, right? Because when ego gets into the way, there's more complications for the patient. Okay, so the representation is just showing different places where you have these axes. So whatever different procedure you're going to make, remember the 80-20% rule. And with that, everything should go well. So this is ultrasound. So this is probably on the right, because we are seeing that more medial. You have the carotid artery, and here lateral you have the internal jugular vein. So yeah, you want to position these two that they're not one on top of the other, but that they're hopefully side by side. Because if you go straight and you go in to this proximal wall and through the back wall, you're not going to have much of a problem. Although it shouldn't happen, you won't at least have the complication of going through the artery, right? So make sure you do you cover your steps. For example, here, if you just press and this is compressible, you know this is the vein. But I go the extra step, I put collar flow on this thing, and I just rule out that this is not so pulsatile as this one. And sometimes it looks redundant, but I like to be 100% sure. So that's what I recommend you doing. So then you have all this kit right here. For all those who are helping out your learners, I would recommend you to guide your learner. I would recommend you to place, as you are the supervisor, so you will put on sterile gloves as well. You will put on a mask, you will put on your sterile gloves, and you'll be there ready if your learner needs help. Not in the sense like, not like this, right? You won't be like this, and you won't be watching over them and being like, you ready? You ready? Do you need help? Can I help you? No, because you're just stressing out the learner, the student, the first year resident, and you're gonna make them fail. Never give the student or learner the perception that you're just there to take over the procedure, that you're just there just to wait for them to fail the procedure because you want to do the procedure. That is a horrible way to try to supervise any procedure. And that's the way I was mainly supervised in my procedures here in the United States and in Costa Rica. In Costa Rica, oftentimes I failed the procedure because I was more immature and I cared more, and I was stressed out about what this aura and these premonitory thoughts that I was going to fail, and yeah, that increases your odds of failing, and they take away your procedure. Here in the States, I've already gone through it once, and this is my second rodeo. I've already done these procedures, whole lot of procedures, so I'm chill. I was completely chill when I was in the learning position, and even if I had this person that just wanted to take away the procedure from me, I was in my mindset completely chill, and sometimes they were telling me, do this, do that, and I knew to myself that I understood the procedure better than most of them, so I was like, okay, calm, why? And I would talk to them, why do you want me to do this? Because this and that, and I'm like, well, I believe that this will work more because of this and that, and they were like, okay. So I would just continue, and they would sometimes be saying too many things like, do this, get this, then. I would be like, okay, can you let me tell you what I'm going to do? And if you agree, let me proceed. And if not, we can talk about it, because this is just stressing me out unnecessarily, and we want to do the procedure on the first run. So yeah, they would usually understand it, and I had no problems. I do not recall any procedure that the upper level had to actually come in and take the procedure, because I was able to perform, I think, basically all of them. Why was this? Because I'm already in this mindset that 80-20%, okay? You're not going to rush me more than necessary. So even if my upper level was like, why are you taking so long fixing everything and moving the patient, and let's go, I'm like, we have the time, the patient is stable, and I want to make sure this goes well on the first attempt, and that's it. You sometimes have to stand your ground respectfully. So here, what I want you to do as a supervising physician is that you don't stay on the side of the bed just sitting just like this and looking over, because your learner might encounter complications. They might be like, oh, the wire isn't passing, and you're going to be like this, and then you'll be like, can someone bring me gloves, right? And it's going to take like 2 minutes for someone to bring you gloves, and there's going to be blood spurting out. So be prepared. So put on your sterile gloves after everything's ready, after you put the ultrasound settings the way the learner will see them right, after even put on some music if the learner wants to feel a little better during the procedure, and calm environment, and tell them, I'm going to put on the gloves just to help you out. I'm going to pass things to you, and I'll be there as your own, basically as an extension of yourself. I'm not here to take the procedure away from you. So that's when you help them, and if they have these, oh, I'm feeling some resistance, you can be like, okay, now do this, do that, and then you can tell them, okay, now I will help you here a little bit, give me a second, okay, now we pass the resistance, you go ahead, do this. And that's how a good procedure will actually go, and that's how people will actually learn. And the reason I'm doing this presentation right now is mainly because I was with my first year resident, my intern, and he was basically telling me that, wow, this is incredible. These procedures have gone so smoothly. And we did yesterday a lumbar puncture, and he told me like, wow, the other day I did a lumbar puncture with someone, and we weren't able to get it, and we were there for like an hour and a half, and we just didn't get it, and blah, blah, blah. And I told him, yeah, preparation is key. So how did we prepare? I even got the ultrasound to see where was the midline exactly with the ultrasound. and that tells you where the midline is, and you can also use the ultrasound to see where the space is between the two spinous processes, and there's where you have to go. We use then a permanent marker or a surgical marker to mark one space, and not only one space. We marked L3 to L4 space, and we also marked L4 to L5 space. So in case one didn't work, we had the other one. We positioned the patient in a way that he wouldn't fatigue, and we have plan A, B, and C. So that's what we did, and we did it. I let the learner do the attempt. After we had everything ready, I told him this is what you're going to do, and he tried it and wasn't able to. And then I gave him some time, and after that, I was like, okay, now I'm going to help you. And I just was able to push a little deeper, and we got into the epidural space. And then I explained, okay, I think this is what happened. You did a great job, but next time just do this. And I explained that when you cross the ligamentum flavum or yellow ligament, you'll feel like you're crossing a piece of paper, right? So you can do that exercise and basically see that. So what I want to get to is that based on my intern telling me that these procedures have gone so smoothly and first pass, I think it's my obligation to share this with you guys because that's the idea, basically. So there's a lot of things. Just don't get stressed out for all the things that are in the kit. Your supervisor should explain to you what is going to be important in the kit, what is not going to be important, and they should guide you through the procedure. Remember, you should be hands-on as a learner. You will never learn if you're just seeing this. You can see 1,000 of these without you actually touching these things. You will never be able to perform the procedure unless your supervisor lets you touch these items and do the procedure yourself under guidance. So just be familiarized with your kits. This is for an arterial line. For example, there's two options. One is this option, which is the arrow kit for arterial line, and this is the other one, which is the dart. So just resort to what you know. So yeah, try to learn all the different procedures, but if you've done 10 of these efficiently and well with this kit, and you have to do another arterial line, and it's a day that you have to do a whole lot of things, resort to this one. Go with what you know. But whenever the day comes that you just have one procedure pending, you already finished all the other work and everything, yeah, try to do it with this new kit with someone who is actually supervising you for it, because that's the way you'll learn. So try to do what works for you and be mindful of your situation, the context, all that. So that's about it with this talk, and yeah, good luck. See you on the next one.